Excellent. So thank you for the introduction, Margaret. Again, my name is Daniel Dale, and I am the Early Mobility Senior Advisor and Education Specialist. I look forward to talking with you today on a three-part series talking about effective interprofessional simulation training. We're going to start off with part one, talking about what exactly is simulation and giving us some boundaries to work with. In part two, we'll talk about some of the accepted standards and how to design an effective simulation in healthcare training. And then finally, in the third part, we'll talk about really considering an interprofessional simulation design and what are some concepts to consider. So if we move to the definition of simulation, and this is taken out of the simulation dictionary as referenced on the left, the second edition, we really talk about it being an educational strategy where a particular condition is replicated to resemble an authentic situation. Again, we're going to dive more into this, but when we think about the authenticity that we can provide during simulation training, it really provides a unique opportunity for our learners to experience things in real life. And we're going to talk about the benefits of that very soon. When we think about simulation as healthcare, as defined by the Society of Simulation in Healthcare as referenced on the left, we think about simulation being the imitation or representation of one act or system by another. Again, we'll talk about these four areas of simulation of education, assessment, research, and health system integration, but I feel that those are all very powerful words that we can use when we talk about the quality of healthcare and how we deliver this to individuals. So the four main purposes as defined by the Society of Simulation for Healthcare, again, first is to talk about education. We can utilize simulation and simulate real life events by creating a bridge between real life experience and classroom learning. We recognize this to be a unique modality. How often have we all thought and sat through trainings or even webinars or opportunities where we're thinking, man, I wish I could just get my hands on and really learn the experience. So simulation provides an opportunity to bridge that real life experience with the classroom learning that you want in your students. Simulation-based assessment means that we can now look at it to improve learning or demonstrate competencies. So it can be used almost as a validation technique to look at skills that you're trying to train your healthcare workers for out in the field or students in an educational program. We look at simulation-based research so that we can use simulation to conduct research on events, specifically, really how do people respond in healthcare situations? We can look at things like in a certain healthcare simulation, how often are people washing their hands when they enter the room in a simulated environment? How often are they responding in a critical situation, such as possibly a code or response to a code? How quickly do they respond? We can research that in a safe, risk-free environment through simulation. And then finally, systems integration, we can look at it for quality assessment. We can really truly understand the data behind why we choose things that we do as healthcare individuals, whether it's on the front line in the workforce, whether it's with our students, we can really assess how we train and how we respond to certain situations. So how can it be used? First, to promote. We can promote learning of a new skill, allowing for hands-on practice. Again, it's to give that idea of here's something you're going to use in real life and here's how you're going to use it, rather than just a textbook or a lecture or video. It can be used to improve. So again, thinking from a manager standpoint or a quality and an assessment standpoint, we can remediate. We can look with employees who have shown skills that aren't at the level that we want them to be at, and we can use simulation to provide a risk-free environment to teach and to help that employee grow to an opportunity where we want them to be. And again, for a hospital situation, you improve the overall quality and the outcomes that you are achieving. We can use it to assess. Again, we talked about responding to a given scenario or situation, understanding that you can now start to understand why those individuals in your healthcare system respond the way that they do through simulation and through research. And finally, to validate. We can look at validating as a competency. It can be used as a skills check or kind of a skills day where you're assessing the skills of the employees that you have or the students that you're teaching. So I reference this a lot when we talk about simulation, but we go back to Bloom's taxonomy of learning and understanding that a lot of times when we deliver material in kind of a standard educational format, whether it be a lecture, a video, maybe an after work meeting, however, a huddle, a rounding with a team, a lot of times we're looking for individuals to learn on Bloom's taxonomy around the remember or the understand levels of the taxonomy. We're really just giving them facts or expecting them to be able to explain the idea or concept back to us, but they're never getting a chance to really demonstrate that understanding and maybe apply it in new ways. So my hope today is as we go through this process, you see how simulation really takes us up the chain on Bloom's taxonomy of learning and allows for your employees to really grow and understand things at a higher level. Again, with the ability to apply using the information in new situations or analyze, drawing connections as they start to see why things happen the way they do through simulation. There are different types of simulation, and this presentation won't go through all of these in depth, but we will show you some examples. But you can use things like task trainers, which may be just a specific body part. These are used often in medical training or nursing training, especially with things like placing an IV, taking vitals, or assessing a pulse. You can use full mannequins, and there are low and high fidelity mannequins. These can vary in regards to technology as well as the cost of the mannequin, but it can simulate anything from a static mannequin all the way to one that has capability of basically breathing, blinking, voicing, etc., to increase the fidelity of the situation. You can have standardized patients in which you have actors or actresses basically that are scripted and are able to respond and provide realism to the situation as the learner is evaluating. Or one that has come up really recently is really the increase in virtual reality, the ability to utilize virtual reality. And we see this a lot being used, especially in my field in physical therapy, in regards to anatomy education. As our students are beginning to learn, it's actually kind of, some schools have chosen to go virtual, and then there's no need for the cadaver lab. They're able to explore virtually as they go through understanding anatomy. So the benefits of simulation are plentiful. And again, I'd be remiss as someone who teaches it and works in it. I see the benefits going on well beyond this slide. But the biggest ones, again, you can standardize a learning opportunity at a higher level of learning. Referencing back to Bloom's taxonomy, we think about how we're accessing higher levels of learning for your staff or students that you're going through the simulation training with. It gives the freedom for the learner to make mistakes in a safe environment. And I think that's probably the biggest key point for me. In teaching our students and working in healthcare, it's not often that we get a chance to provide training that is hands-on where there is no risk to the patient. But in simulation, we get that 100% of the time. Every chance you have to teach in simulation can be made to be risk-free, and the student can then be assessed and evaluated as they go through. Learning can be customized, and we'll talk about that as we talk about our interprofessional education opportunities. And finally, detailed feedback can be provided through debriefing and reports to all participants. So that brings us to our first polling question. I believe Margaret's going to open up the poll, but the question is, which of the following is not an appropriate use of simulation in healthcare training? So it'll give you just a little bit of recap, and it looks like the poll is open now. So we'll ask you to put in your votes.
If anyone's having any challenges with the polls, let me know in the chat box. But if you can, click on which one you think is correct answer. About half of you have voted. If you haven't voted already, go ahead and we'll give a few more seconds to finish the voting. All right, so I'll close the poll and share the results. It looks like about 50% Dan assess response to a given scenario, and 50% say all are appropriate uses. So I'll give it back to you to further discuss that.
All right, and the answer for that one is that all are appropriate uses of simulation in healthcare training. So good job to about half. And then we'll move into the second question.
Okay. And that one is, which of the following is not a benefit of using healthcare simulation as an educational tool? So we're going to give just a minute or so to get your vote in on this poll.
And I'll say that this question is actually a leading one that will lead into our second unit here. So it isn't something that we've necessarily touched on, but will lead us into where we'll be in a minute.
right, again, about 50% have voted, and then if just give it about 10 more seconds if you haven't given a stab at it. And again, in keeping with the simulation environment of safe learning, don't worry if you are not sure if it's the right answer, because we're going to talk about them and go through them. All right, let's close the poll, share results. It looks like 100% of people said takes less time than traditional classroom teaching.
That is correct. So they're right on with that. And we'll talk about that as we move into the standards of simulation. All right, excellent. So we'll move into the second part, just verifying now that you can see my screen again as we moved off the polls.
Yes.
Perfect. So we'll move into what we're going to describe here is using the INAXL standards to design a simulation. So this part of the presentation is given and discusses the International Nursing Association for Clinical Simulation and Learning, their free resource that's indicated here, which is on simulation design. We're going to talk about this and give some examples from my experience in simulations that we've created and discussed, but we'll go through kind of the INAXL standards. This is really the gold standard, and it's a fantastic reference when you start looking at how to design a simulation. It really walks you through example by example of each of these standards. These are the standards as all listed out, and we're going to break them down and go through each one. So it just gives you an idea of really how in-depth this reference is. So when first deciding how you want to go about creating a simulation, the first step in what you want to really try and do is perform a needs assessment. That involves creating and conducting an analysis of need, again, conducting surveys of stakeholders and defining what you want your outcomes to be. In this needs assessment, one of the critical steps that sometimes is missed is making sure, especially in an interprofessional or healthcare-driven environment, that we include all necessary disciplines in regards to the assessment of need. Oftentimes the simulation, and we'll talk about this as we get further in, the simulation may not be successful because the needs weren't considered of certain disciplines as you moved into it, and then you tried to make it more of an interprofessional simulation. So we'll go through some of those examples. The second step is really looking at making measurable objectives, which means you've got to determine what do you want your outcome to be, and then creating SMART goals, really thinking about those goals that are specific, measurable, achievable, relevant, and time-based as you go through these outcomes. Having vague objectives usually will lead you to an unsuccessful simulation scenario because your learners don't necessarily know where they're headed, and sometimes you as a facilitator will be led off course because you don't have the clear objectives that drive you towards that outcome data. Then you want to go about choosing the format of the simulation. And what I mean by that is thinking back to kind of one, what sort of modality or intervention do you want to use? Whether it be a task trainer or maybe a standardized patient or a mannequin, what kind of format do you want to have? And then you also want to consider kind of the outline of time and where you want to spend your time. We'll talk about two of the major objectives really are the pre-brief and then the debrief and how important those are to a quality simulation, but you want to think about your time settings and where you want the students to be. Oftentimes, and I made this mistake when I first started conducting simulation and really developing simulation examples, I thought, you know, let's make the simulation long. Let's make it a half hour to an hour. And the students are really thinking the whole time. And I found that that created a long list of objectives and watered down all of the results of what I was getting. So a lot of my simulations now are really maybe 10 minutes in length, maybe 15 at most. And it still allows me to see clinical reasoning in my students and allows me to really assess and drill down to certain objectives that I want to achieve through simulation without getting too lost along the way. You want to consider your clinical scenario or case next. So sometimes I think people start at this step before the needs assessment and how they want to do it. They've got their case and then they start trying to draw up what it looks like in simulation. And I'll tell you from personal experience that can be very challenging. So you want to ensure that the case is of quality and that it's valid. And that means having peer reviewed. People looking over your shoulder to make sure that the case makes sense and clinically is accurate based on the learning that the students or the healthcare providers are going to come in with. You want to provide a realistic starting point. You want to provide that clinical progression, and you want to consider things about queuing or refocusing participants. Every simulation, no matter how tight you draw it up, you'll find that some of your learners will have alternate ways to approach things, and you want to find a way that allows them to refocus or allows you to intervene without taking away from the fidelity and the realism of the environment. So you want to make sure that you have kind of those cues built back in, so that if there's something that they go off track or they maybe get the wrong cue and are going down the wrong path, you can steer them back without taking them out of the simulation scenario. I've talked a lot about fidelity, and we want to consider fidelity, which is really the realism of the environment. And you want to consider things related to the physical, conceptual, and psychological fidelity. Physical is going to be the environment. It's going to be what are we using, where are we located. So one of the examples I'll show you is we're in a nursing student lab, and you'll see in the pictures soon, but we've made it as realistic as possible to make it look like an ICU. So we have a headboard, we have all of the lines and tubes and devices to try and allow when the student comes in to really feel like they're in an ICU. We also play, and it's really related to the psychological side, we play sounds and noises related to the ICU so that when students are communicating, it's just like it would be in an ICU. It's loud, it can be difficult to communicate and hear properly based on what's going on with the scenario or the situation. You want to consider also your conceptual fidelity. So that's the things like, how do things relate to each other in the environment? Such as if I have a patient who might be prone to be orthostatic and they sit up on the edge of the bed, I need to adjust their vitals. If I'm using a mannequin, I can do so, and I can adjust their vitals appropriately so that we can now see how the learner responds to the situation as it happens. Versus, if we don't have true fidelity, it might be me as a facilitator having to say, now your patient is orthostatic, and it's really taken the student or the learner out of the environment. It's taken them away from the realism, and now they're responding to what I've said rather than what they've experienced or seen, which is what we really need in the healthcare environment. We can also use what's called moulage to create fidelity, and that's really the art of simulation, how we create items that look, smell, hopefully not taste in the healthcare environment, but really appeal to the senses so that we know that we're really truly in one of these environments. You want to consider what kind of approach you have as a facilitator. So whoever is going to be leading the simulation, you want to consider it to be participant-centered. And this is a big key difference from simulation training or education versus traditional didactic education or learning or teaching as we consider it. Facilitative approach in simulation is really that this is participant or learner centered. So you as a facilitator are actually doing less in the moment. There's a lot of prep work that goes in, but in the moment you're really stepping back and allowing the learner to participate and learn, and then you're facilitating more the debrief or the after experience. It should be driven by your objectives. So whatever you're facilitating is really driving home, instead of having a vague discussion during a debrief, you're really driving home, what were my objectives, and here are my questions that I'm going to ask to get the learners to understand those objectives. And again, you want to consider the level of your involvement. Oftentimes, if I'm the facilitator, I'm trying to do things like not be in the room and be behind a screen or a glass wall where I can still see the learners, but I'm not even there for them to look back to for any confirmation that they're doing the right thing or any idea like that. It's really supposed to be a safe environment, but an environment which the participant or the learner drives the learning. Pre-briefing, as I stated earlier, pre-briefing and debriefing are probably the two most essential parts of any simulation to make it a success. Pre-briefing allows you to set the stage for participants and it identifies your expectations. And that can be anything from sharing some of your objectives and sharing with them what the clinical scenario might be that they're walking into, giving them a brief background on the case, helping them understand what setting or scenario they're in. It can also be expectations related to how you want them to treat the simulation. Oftentimes, for people who are learning for the first time to participate in simulation, it can be sort of humorous and even uncomfortable because they may be, carrying on a conversation with a mannequin. But as soon as you allow people those expectations and they understand what you want out of the situation, you allow them even in pre-briefing maybe to interact with a mannequin to see how it works before they get into the simulation, you'll find that you get much better outcomes and approaches by your learners. And again, like I said, establishing the environment, letting them know where they're heading into and what they should expect to see. In a debriefing, you want to use a planned debrief or feedback session. And oftentimes it's referenced in the Anaxel standards, but I would echo it as I've gone through different simulations. You want to consider that your debrief should be about in a 2-to-1 ratio related to how long your actual simulation is. As you move through, you want the debrief to allow time for your learners to really experience and demonstrate that they've showed learning related to the items that you've just covered. You also want to consider the difference between what a debrief is and what feedback is. Feedback is really going to be maybe how you start a debrief in talking about their performance. Maybe you're touching on things they did well, things they might be able to do better. But the debrief is really looking into their feelings and their thoughts about how things went, and maybe thinking about future experiences. What could they do differently or in a different manner as they walk back into that room in real life? Again, with the goal of simulation being, we're allowing our learners in that safe environment to experience some hands-on learning. We want them to carry that forward into real life as soon as possible. So we want to see that proper conduct and then move into that real life experience with those same skills that they demonstrated. You want to consider the evaluation, and this is many different aspects that you want to evaluate. You first want to evaluate your participants as they've gone through the simulation. If it is something that you're using to validate or remediate an employee or a learner, you want to figure out how you're going to evaluate, did they accomplish what they needed to accomplish in the simulation for your standards. You also want to evaluate the facilitator. So that may be you, or you may be part of a team in which you're not the lead facilitator, but either way, you're going to evaluate, how did the facilitator handle the debrief? Was the facilitator involved enough or involved too much throughout the simulation, which how did that affect how the learners learned? Then you want to evaluate the experience, the entirety of the experience. Did it work the way you wanted it to? And I'll share that oftentimes my first time simulations don't work the way I want them to. We'll get some aspects of our objectives, but we realize where the student or the learner may go off course, and we can adjust and redo as we go through that. Evaluate the facility. For some of you, if you're lucky enough to have access to simulation technology or simulation lab or even simulation tech experts, technical assistants, you can really evaluate the support team in the facility and get a better idea of how did everything work together, and are there things you can do better going forward. On top of that, related to evaluation, you also want to make sure that the evaluation flows both ways. You want to make sure that you gather the data from the learners on the simulation. Did they feel like the simulation was helpful? Did they feel like it addressed the outcomes and objectives that they needed to see or hear? And what were things that could be done better? That goes back to one of my first simulations that I said was too long, and that was actually feedback we got from the learners, was that some of our objectives were lost in the weeds a little bit, that as the simulation went on, we should have shortened it and been a little better. And that was great feedback to receive. So you want to make sure that you're getting that feedback in all directions. Finally, you want to consider participant preparation, and this can vary based on how you're using the simulation and potentially what your outcomes and objectives are. You want to develop those preparation activities that can address knowledge, skills, attitudes, and behaviors that you want from your learners to complete the simulation. That might be a review of things, and we'll go over an example in a little bit, but might be reviewing skills or knowledge that they already have as they prepare to come in. It may also be preparation, might be that 5 or 10 minute pre-brief. That may be all that you give your learners, depending on how you're using the simulation. But you want to make sure that they come in prepared, and the simulation is not necessarily a surprise. But I will share with you a situation where we use it as a surprise. You want to assign specific activities again and include information such as code of conduct and confidentiality, especially if you're using a simulation related to validating skills or evaluation of an employee. You want to make sure that employees understand that that is confidential information, because sharing that information with the employee coming after you helps them better prepare if they know what the scenario is going to be. We use it in a learning environment, and actually the majority of my simulations are specifically just to learn. It's not for validation. We don't use it for competencies as much. And in that regard, I still keep a code of conduct and confidentiality, because it ruins the experience for the next learner. If they know what's coming, if they know what the next experience may hold, they come in and they don't have that real life experience and real life learning of how would they react if they didn't know something was coming or to be prepared for it. And then finally, you want to really pilot the simulation experience. This means piloting the entire thing, making sure it meets your objectives and runs smoothly. So find faculty or other staff members or your simulation team and work through the entire scenario and make sure it works the way you need it to. This way you can identify gaps, you can correct them before the simulation starts, and then you can also assess your evaluation tools to make sure that what you're evaluating is actually performed in the simulation, so students or learners feel like they have an adequate grasp of what you're evaluating. We'll share a story about pilot simulations as well in just a second. So this is an example of a simulation design. This is one of my interprofessional simulations that I run on campus between our Doctor of Physical Therapy students and our undergraduate Bachelor in Nursing students, Bachelor in Science in Nursing. And so what we do, to give you an idea about this scenario, we recognized, and this is where we got our outcomes and our needs assessment, we recognized two problems that we had when talking about interprofessional discussions between physical therapy and nursing in the professional workforce. We found that a lot of times our faculty noted that role recognition was very difficult, where sometimes our physical therapy students coming in didn't recognize all of the roles that nursing was performing within the acute and the intensive care environments. And we recognized vice versa, that nursing was not quite aware of all the roles and responsibilities that physical therapy would play, especially related to early mobility of a patient. We also reported with our students, they reported a high level of anxiety related to just being in acute care or intensive care. And we recognize that that's prevalent across healthcare disciplines, that the ICU can be anxiety producing. So our objectives were really looking at how can we decrease that self-reported anxiety pre to post simulation in physical therapy and nursing students following the completion of it. The format of the simulation was what we laid out, and we really had 3 different simulations that the students cycled through over a period of 3 hours. But each simulation, active simulation piece, was about 15 minutes. PT and nursing students worked together in groups of 4 to 6, and they would work through different simulated cases. The one that I've highlighted here is there's an early mobility case, and then a case where the patient actually has cardiopulmonary arrest, and they have to go in and perform CPR. In the case of the early mobility related to lines and tubes and managing a patient who is very complex from that situation, the students are prepped and given prep activity to go over lab values, lines and tubes, and making sure they understand the acute and intensive care environments before they go in. They also go over principles of early mobility related to how to mobilize a patient safely and what are the risks associated with it. Meanwhile, in the cardiopulmonary arrest situation, the students are not briefed. The pre-brief actually tells the students that they're going in to conduct a discharge evaluation of physical therapy and nursing together. But within about 30 seconds of being in the room, the patient starts to show signs of distress and then codes, and we lead a full CPR effort. And this is where I talked a little earlier about how pre-brief can vary a little bit, and some you really want to prepare the learners and some you don't. Again, we don't use the CPR as a validation or an assessment. It's a learning experience, and it's a real life scenario that may happen to the students while they go into a room where they have to respond and think clearly in times that can be a little chaotic in the healthcare environment. Our clinical scenario or case, again, is students are in one room. The facilitator is actually present in the room for these, but doesn't really talk or lead other than the cues that we provide to get students back on track if they start to move away. And from a fidelity standpoint, we're using high fidelity mannequins who have the ability to respond to situations. And we also have ventilators, lines and tubes, plenty of noise and other things going on. So when we think about the facilitative approach, we spoke about that a little bit, but really the facilitator is just doing the pre-brief and introduction, and then they do lead the code team once the code occurs. Because of recognizing that anytime in a code situation, it would be difficult without letting the students know ahead of time that one of them would need to lead the code and that communication errors could set in. So our facilitator actually is the team leader during a code situation, which helps further the learning of the students. Again, we've talked about pre-briefing a little bit, and then our debrief. Really, our debrief is 2 times as long in each of those scenarios. So the students are in each scenario for an hour, but they really only do the simulation for about 15 minutes. And then we spend a good 30 minutes in each one debriefing what they've learned, where they're at, and what they're going to take from the experience. We performed our evaluation after the experience, and the students love this type of evaluation. They talk about hands-on learning and experiential learning being so great for them. And they also go through and talked about how they feel less anxious. And we measured their anxiety with a couple of different scales and found that students were less anxious now about some of the scenarios, even though it was anxiety producing to go through it in the simulation. Their participant prep we've talked about, but really they're learning through lines and tubes and thinking about the environment. And finally, when we piloted the experience, it was myself and 2 of my colleagues who worked together on the kind of early mobility education related to our PT and nursing departments. And we piloted it by actually going through it together with each other. And funny enough, with the early mobility scenario with a patient who has multiple lines and tubes, we found out that we had actually set up the room to not be successful when we piloted it, that we couldn't actually get the patient up safely based on how we had assessed the lines and tubes and set it up. So it allowed us through the pilot to really reset the room and the fidelity of the situation to make sure that the students could be successful as well. So that's a good plug for doing a pilot simulation experience. So I'll show a couple of pictures just so you get an idea of kind of how we've set up this environment. This again is in a nursing lab, but it goes through kind of the ICU setup and what we've applied. And we talked about having monitors available. The ventilator we use in this picture, this is an older one, but we actually created just a paper model and we downloaded sounds to add to it. So we were really looking for the fidelity of the lines and tubes. We have actually acquired a ventilator since then, so we have something that can roll and move with the patient. And the patient is in there hooked up to lines and tubes, and that is a high fidelity mannequin who will blink and respond to the situation as it goes on. So the students are tasked with really talking to the patient as they're getting ready to perform what can be a very anxiety producing activity for both our learners and for the patient themselves. This is another picture of our physical therapy and nursing students working together and really looking at how they mobilize an individual. So the individual has a chest tube, has multiple JP drains, has a wound vac, has all sorts of issues going on, is intubated. So they're really working through how do we manage the lines and tubes and communicate together. And this is where we got into our objective related to role recognition. It was interesting to note the students really didn't know how much education both sides got from a physical therapy and nursing side related to early mobility and safety in the ICU. And they found out by doing this simulation, they were able to go through and really assess each other's learning and were very just excited about how much each other knew about what was going on in the ICU department. We found that through our study, it actually conveyed a lot of feelings of pride and respect between disciplines, and that's how you can use that simulation to enhance knowledge base of different learners. And then finally, this was related to our CPR code scenario, but again, our physical therapy and nursing students working together in a code situation. So it just shows you a little bit of how the simulation and the fidelity is set up. Off screen to the right is where our facilitator is located as the team lead, who's talking through and kind of viewing the room and keeping everybody on track. So again, I can't stress enough, the Inaxel standards and the simulation resources that are provided by Inaxel are top notch and really will help you guide if you're thinking about simulation as an education modality. Make sure that you go through that. They have other simulation resources that are available related to how to conduct a proper debrief and tips and tricks for that, as well as things like operations, how to actually start a simulation lab or look at what you need to conduct simulation in a space that may not be conducive to lab or technology. So you can go through and really access those resources, and they're wonderful resources to get you started. And that brings us to the end of our second section, and we've got 2 more polling questions just to check where you're at and kind of understand your own learning so far.
All right, so the first poll is going to be the following order would represent best practice when designing a simulation. Select one of the following. Either you do your needs assessment, create objectives, then select your format and write the scenario last. Again, I'll let you read through the poll. We'll give a couple of minutes for you to watch and try to click on what you think is the best answer. And just while we're running the poll here, I just want to share a couple of questions that have come in, and I think maybe you've addressed one of them already. How do you know when participants are ready for sim training? Do you have certain competencies they need to show before they're ready? So I think you touched on that. And then secondly, is there an optimal number of participants that you set when you are setting up a simulation?
Absolutely, I can answer both of those. So with the first one, how can you tell if your learners are ready for simulation? I'm of the thought process that it is any time you want to do simulation, you can conduct simulation as a learning objective. Again, that goal of providing a safe and experiential learning environment for a student is so strong that there isn't really a time where I would say they're not ready. You want to make sure in that preparatory activities that they have the baseline knowledge of what you want them to do. So for example, just using say a nursing example for our nursing students. If they've never administered an IV and you've never taught them about the standards related to you know, gloving and hand washing, hygiene, and all those things, that would not be a great time for simulation. There's still some didactic learning to be done before you can turn them loose in simulation, because otherwise your objective list would be so long because they have so many tasks you need to teach them. But if you've given them some of the prep material, it doesn't mean they have to have mastery of what you're trying to get them to show in simulation. It's a great opportunity for them to learn by doing. So.
Great. All right. Thank you. So results are in. 100% said needs assessment first, then create objectives, then select your format, and then lastly, write your scenario.
That's exactly right. So yeah, you want to really go through that needs assessment first. And again, that's where I find individuals sometimes struggle with that, is forgetting to do the needs assessment and then going through the objectives. All right. So then our second question. So the simulation should contain all of the following elements except.
So we've got pre-briefing, debriefing, participant preparation, evaluation, or simulation should contain all of the above.
And as you're answering this one, you may harken back to that first section in the question we had about simulation. And remember, we said that the one thing that wasn't true was that simulation can be done quickly and quicker than kind of academic teaching and didactic learning. So as you're starting to see, simulation can take a long time as a modality to intervene, but we'll talk in the interprofessional part in part 3 about why investing that time is really helpful.
Great. And 100% of the attendees, Dan, said simulation could contain all of the above.
Perfect. Excellent. And can you remind me, Margaret, again, what was the second question that had come in? I want to make sure I address that before we move into the final point.
Is there an optimal number of participants for a simulation?
So that is a really good question, and it really depends on the modality, how many people you have as facilitators, the space of your room, because one of the things with Fidelity is you don't want to try and put, you know, 20 people into a small hospital-sized room and try to learn and have them moving around each other. I don't know if the Anaxel literature talks about an optimal size. We usually aim in any given scenario, we usually have about 20 to 24 students in the building, but they're usually in smaller groups of 4 to 6. And even for that, that's a little big for us. I would actually prefer it to be a little smaller, but it really depends on what you have the capacity to do. You can do simulations as low as 1 person at a time. It can be, we're going to bring you into the room. If that is the situation you're trying to train somebody for, say that you're trying to train, say a physical therapy student, and you're working on early mobility and you need them to mobilize a complex patient out of bed in the ICU, and normally that would be done by 1 staff member, then you may decide that your simulation needs to be 1 and at most 2 individuals together to kind of go through and figure this out. If you allow for those larger sizes of simulation, then some learners are going to miss out. They may not get the hands-on piece that you want them to have because there's a multitude of learners in the room. And we also know that sometimes in those groups, people can dominate the learning or the simulation approach. And so you might find that some people fade into the background a little bit. So I think that's part of your needs assessment, is thinking, how many people can I get in the room? How long will it take me to run that many simulations? So if you're part of a large healthcare system, and you have to train 100 or 200 nurses, then obviously one-on-one is going to be really difficult. So you want to consider how you do that. But great question.
Fantastic. And I just would remind everybody to please ask your questions in the chat box, and that way Dan can continue to answer them. Thank you, Dan.
Absolutely. And we'll have a little time at the end here as we finish part 3. All right, so now we're going to talk about designing an interprofessional simulation. And again, not knowing necessarily the audience that's on, but recognizing that many of you may be in healthcare facilities where you're managing multiple disciplines. We really want to think about how we create simulation that's meaningful across all disciplines. And that's what I hope to kind of go through with you today. Points of reference, again, we're going to reference the Anaxel Standards Committee. They put out the best practice of simulation enhanced interprofessional education. So some of the material will be pulled from that. And then also the article by Bowitt and all that talks about 12 tips for successful interprofessional team-based high fidelity simulation. Both great references, and you'll see that I've inflicted a little bit of my own personal knowledge and points that I've learned along the way with these. So these are the considerations we're going to be talking about as you develop kind of an interprofessional simulation. And this really goes into your needs assessment as well as thinking about kind of piloting the experience. You want to think about these opportunities, and we'll dive into each one by one and give you a little bit more insight as to what we're talking about. So if we start, you want to think about who your audience is. And the first easy question if we're developing an interprofessional scenario is what disciplines are represented. But beyond that, we also want to know kind of what's the level of knowledge. Are you working with new hires? Maybe you're doing simulation training with new hires to assess competency at a baseline level. Are you working with individuals who have been there for 20 years who maybe have developed habits that you're trying to change or rectify? So you want to know the level of knowledge, and that's across the disciplines. You don't want to come at this by saying, potentially we're going to have maybe physical therapists who have been there for 20 years, nurses who have been there for 10, rec therapists who are, respiratory therapists who are new hires. You may not necessarily want to blend as much of that if you're looking at different objectives, because that may make it a little more cloudy in how you create the objectives and what you're aiming for your learners. If you can, you want to gather things like what types of learners you have, whether people are really comfortable with experiential learning. If they've done simulation before, a lot of your medical professionals, your physicians, your nurses have encountered simulation training. Physical therapy has really just jumped on to simulation training. So a lot of our students who may be coming in the workforce maybe have never experienced simulation. And so that's a little different. You've got to kind of get them ready and prepared with more preparatory activities versus sometimes some of our medical colleagues in other disciplines. You may want to think about preferred methods of communication. And obviously, you may not have a communication assessment of every learner that's going to come through, but think on a discipline or maybe a department basis. If you're working with a department, what do you know from the managers about how they communicate? Are they open to kind of the change in the learning environment, or does it tend to be a little bit more of maybe a department you're trying to bring along who isn't performing up to speed? And that will help you kind of think about how you assess the needs and going into the simulation. I think it's a really important question to ask, but think, why are they here today? Did you have to mandate something to get them in the room, and are they excited to be there? Is it an optional learning experience that you're offering to enhance skills and really move up and beyond to make you an even more standout association? And consider, are they on their normal schedule? Are nurses coming in on a day where they're off shift? Because that may affect how their learning is really going to be impacted if they're willing to be there, or perhaps it's something you've called last minute as a simulation activity. And then again, consider the morale of the team that you're bringing in. Do they know they're achieving? Are you working on doing something that's above and beyond what they knew? Or are they underachieving? Are they working and they know that they're kind of doing this as a punitive device here? So you want to think about how you're approaching your audience. When you think about the existing culture, this kind of goes along the same way. But are you working to fix a technical problem? Maybe it's the fact that you've had a rise in CAUTIs, or you've had a rise in falls in patients, or maybe you're establishing an early mobility program and you're trying to fix a technical problem related to that. Or are you working to fix a culture problem? And really, is that culture known or unknown? If you're working to fix a culture problem, simulation training can be good and it could backfire as well. You want to think about who's in the room and is that culture going to affect how learners are learning. That also goes along with our fifth bullet down a little bit below, so I'll jump down real quick, but you want to ensure again that it's a safe learning environment. We've talked about safe from the perspective of learners can make mistakes without harming a patient. But you also want to consider safe from the effect of learners are safe and what is done in the room is not held against them. You don't want culture started where individuals had difficulty with a simulation and now it goes around that they're a weaker member of the team or they're not as knowledgeable. So you want to make sure that as part of your code of conduct, you also establish that safe learning environment where people feel the ability to jump in and be hands-on without fearing reprimand from managers or from other team members. Again, you want to consider, is this a new problem you're fixing or is it an existing one? And what are the methods people have tried to fix before? If you've come in and a lot of learning and in-services have been done and they haven't been effective, it's a great way for simulation to come in and really fix it, where you can have some hands-on learning and reframe the discussion around what you want. You want to consider discipline-specific experience, as we talked about before, and include people who are your discipline-specific champions. You'll get the buy-in from individuals who maybe are the leaders in the department or leaders and managers on the floor who can really help get the buy-in from other staff related to the culture. We've talked about level of experience and age, but we'll take this a bit further. But again, is the simulation specific to new hires? Are you branching across all employees or disciplines? And if the simulation is for everyone, do you consider it to be the same? So are you going to run the simulation in the same way every single time to create, I would suggest that if you're looking for things like validation of skill, you want to run it the same way every time to make sure that employees are on the same level if it's a skill that everyone should have. If you're looking at more of an experiential learning, you might branch off with some of your more experienced clinicians or physicians or whatever position. You may have it be different for them than it is for the novice learner who's just coming in, and really you're developing different simulation scenarios there. And finally, you want to really consider generational differences in preferred learning and communication styles. So this is something that I also teach, but I'll put a caveat out there that I believe that I think we do too much to separate generations and too much to separate communication styles. We really have preferences, but as long as those preferences are met, we shouldn't necessarily separate people into different generations and things like that. However, for the case of this, we will talk about some general trends that are accepted in most of the literature. When we talk about some of our later generations, Gen Y, Gen Z, and the millennials, typically those generations are more comfortable with technology. And so in my teaching, I'll tell you that for my younger students, they actually find the simulation really cool, in their own words. They find that it's innovative and the next level of thinking. They love the virtual reality in different scenarios when they see some of the technology at use. They also prefer that collaborative kind of safe space where they can explore options for learning. For some of our earlier generations, Gen X and baby boomers, just recognize that for some, and it's not for all, and please know I'm not stereotyping, but it may take longer to orient for technology. So you may want to consider that with your learners, that your pre-brief or your preparatory materials may need to be a little bit longer to make sure that they're comfortable with the technology. Finally, you want to prefer, they may prefer more instructor-led courses or self-learning tools. So you may want to consider some of that self-learning up front and then keeping the simulation a little bit smaller or more narrow so they can come in and just show the skills that you want them to in the simulation environment. Again, consider, are you learning something new or are you fixing a problem? And if they're learning something new, think about how it comes across to your employees or to your learners. Is it going to be used for evaluation or validation at some point? Because that immediately ramps up a little bit of the stress and anxiety for people performing. That may be what you want out of the simulation because you need to see the skill performed, but it may not be. If you're not using it for evaluation, you can talk with them about how it can be a practice or a learning environment so that they enhance their skill and they become better at it. By being open and honest about that, that helps the learners know what you're trying to accomplish and how they're going to respond. Again, if you're going to be evaluating, is it going to be right now? Is this the first time they're going to do it and then the second time they'll be evaluated? Or is it going to be a one shot? This is the simulation and this is what I want to see you do, and you'll be evaluated as you perform. Again, it sends a different message to your learners. And finally, will all disciplines have the same assessment? If it's a skill that everyone needs to know, such as say, you're doing maybe a checkoff for lines and tubes and assessing lines and tubes in a room, making sure that everyone knows the safety precautions around lines and tubes, that would be a skill I would think that all disciplines that are involved in early mobility or intensive care should have, and they should understand what all lines and tubes are, and therefore the assessment should be the same. Versus if you were doing things like, say, restraints on a wheelchair for a patient who had cognitive impairments. That may not be the same based on how different disciplines interact with the patient. So you may consider some of those differences. And then finally, if you're fixing a problem, how quickly do you need to fix it? Because that again will add stress to the learners. And it may not be something that then is conducive to simulation. It may be something that needs to be fixed right now and have to do kind of a didactic learning approach and then an immediate skills check. Let the learners know when the evaluation will occur. And finally, what are the outcomes if learners are not successful? I think being clear, if you're going to use it as a validation or an evaluative tool, that you're clear with the learners, what does it mean if you're not successful and how will we help you remediate from there? Consider if you're going to teach to experience or to validate. We've touched on this multiple times, but again, if you're using the simulation to teach a team a new skill or introduce something new, then it's typically not going to be an evaluative criteria. You're really just teaching a skill and letting them see it and be hands-on with it. If you're using the simulation to increase the team experience or to fix a team problem, your objectives should really rely on that. So your objectives, and this is a problem, again, I talk about with the scenario I developed, That first scenario I told you about that we do with our PT and nursing students, I had a list of objectives. I wanted to see the students perform, the early mobility piece. I wanted to see them perform management of lines and tubes. I wanted to see them talk with nursing. I wanted to see them perform an S-bar with the patient. There were so many objectives that the students, it got so watered down. And really my main objective was to see that team experience and work on safety in the environment. So once I had a chance to really go over that with the facilitators, we worked on it and we got it down to really 2 main objectives. And that allowed the team experience to show and not let the students get watered down in so many objectives of what they needed to accomplish. And then finally, if you're using it as a validation tool, as a skill for the team, so this is oftentimes used in situations like we described with a code scenario. If you're going to evaluate the team's response, just be real clear about that and make sure that all team members are on board and understand what their role and what their experience is going to be, and that you validate fairly across the different teams. This is a big one for me, but consider the structure for the disciplines involved. Make sure you've consulted with your simulation team and all the disciplines. Make sure you have mutual goals for all, and make sure that you're really ensuring a safe learning environment, especially if there's a culture situation. If you find that 2 of your disciplines don't get along and then you throw them together in a simulation without really clear objectives and real clear code of conduct, it won't go well. And you may actually end up with a bigger problem than what you started with. So make sure that you're really ensuring that that culture is first and foremost what you address during the situation. Make sure that it's both diverse but equitable across disciplines, and make sure scenarios are relevant for all and that it's consistent with your facility's kind of culture and sociologic construct within your facility. Consider if you're going to do reciprocal versus team teaching. So reciprocal teaching might be where I have 2 disciplines in the room doing a simulation, but really it's one discipline showing what they know to another discipline so they understand. So for example, in the early mobility assessment that we did between nursing and PT, if I had drawn the simulation to say that PT was going to come in and instruct nursing on how to move lines and tubes and assess their patient setup, that would be more that reciprocal teaching. But my students wouldn't be getting as much out of it other than talking to nursing, and that wasn't our objective. We wanted to make sure that both disciplines knew the roles, understood the responsibility, and really had value for each other in that situation. So we had it not be a reciprocal teaching, but really a team simulation where the students decided who was in charge, who was going to lead the simulation, and who would be performing what parts as they went. Again, you also want to consider if the situation feels genuine or artificial. I'd caution to not throw in disciplines that don't naturally get involved in certain situations. The more people you have in the room, the less genuine it's going to feel for everybody. Again, if it's normally 1 or 2 people going into the room, putting 5 or 6 in there is not going to enhance the learning. It's actually going to draw away from what you're doing. So think about the genuine involvement of everybody in the room. And then again, set your clear objectives. Make sure that you're allowed to provide feedback from both the participants as well as other people involved, the facilitators. Make sure that your objectives are focused enough, but not too focused if you're involving multiple disciplines, because again, that may exclude some disciplines from being involved if you're too focused. And make sure they're appropriate for all team members to play a natural role or part. Finally, your assessment, make sure that everybody has a chance to provide feedback. And really, a lot of times that feedback is taken both by the facilitator that's discipline specific, but also then by the larger group to understand where each discipline is coming from and make sure everyone feels safe when providing that feedback. Leave your time for debriefing. Again, so make sure you've left approximately twice as much time as the simulation for debriefing. And then think about the role of the facilitators in debriefing, because that can also leave a lasting impact on the learners. If you have 3 disciplines present, but only one discipline leads the facilitation of the debrief, it tends to leave the learners with the perspective that that facilitator and that discipline was the most important. So make sure that each facilitator has a chance to really lead the conversation across all disciplines and share their part. Finally, I want to leave, and I know this is part of the handouts that you guys have with the presentation, but the National League of Nursing has provided some helpful resources, and I've provided a link above. Excuse me. But in their Simulation Innovation and Resource Center, there are templates that they have that you can actually use for non-commercial use for simulation design as well as IPE simulation design. And they have included information again about useful debrief or pre-brief sessions as well, and kind of can guide you through some of the tips that we've talked about today. So on top of the Enaxle resources, the National League of Nursing is another great resource to look into. And with that, I think we'll turn it over. We can either go to the final poll questions, or I know we're running a little low on time. Margaret, I didn't know if there were other questions we could answer.
Great. So thank you, Dan. I think what we're going to do is I'm going to unmute everybody, and rather than doing the last couple of polls here, which are reviewing, we'll give a couple of minutes for questions at the end. So I'm going to unmute everybody. Please feel free to ask questions, or you can type them in the chat box. We've just got a couple of minutes left, so please let me know whatever questions you have. And know that you have the handouts that you can download right in the handouts section. So any questions from the group? So I have one here. Frequently, I have multiple disciplines and I struggle with evaluations coming back from experienced staff that they didn't learn anything. Yet the experienced staff don't want to participate. So maybe better to separate them?
I would say maybe two things. It could be that you want to separate your learners. Again, you want to look at your outcomes and kind of your needs assessment. Are you creating something that's at a high enough level that gets all of those staff? And it might mean more work on you if you're the educator that's creating the resources, that you have to create more of a novice level simulation. And then I would dive into that needs assessment with the experienced staff. And it doesn't have to be a formal evaluation, but maybe it's a conversation over lunch of, what about the simulation did you not get something out of, and what can we do to enhance it? And they may tell you directly, these are the pieces that we really struggle with. Or, sometimes what I find actually is engaging your experienced staff in the creation of the simulation for more your novice learners really helps them understand the modality and may bring about some ideas of how they want to see it used for more experienced staff. But it may be that you've got to run a couple different scenarios if the level of learning is so diverse that you can't create a simulation that meets all needs of different learners.
Great, thank you, Dan. And just thank you from that participant. Any other questions? We've got time for one more. And I wanted to remind you all, while we're waiting, this session is being recorded and you will receive an evaluation. We'd greatly appreciate if you can return that evaluation. Let us know how we can better serve with your educational needs. And I don't see any more questions. So thank you so much, Dan. And thank you all again for attending today.
Thank you, Margaret, and thank you everyone for your great questions and for your attendance. I greatly appreciate it.
All right. Thank you very much. Bye-bye.